S.O.A.P for physical evidence as medical evidence, a forensic investigation framework, including gunshot wounds and burn forensics. Welcome to today's forensic learning session. In this video essay, we explore how the S.O.A.P framework, subjective, objective, assessment and plan, becomes a powerful, structured tool for documenting physical evidence as medical evidence across clinical forensic medicine, sexual assault investigation, forensic pathology, criminology, forensic psychology, and nursing. Today's expanded session also includes gunshot wound forensics and burn forensics, two critical domains where precise, neutral, and trauma-informed documentation protects both scientific integrity and human dignity. This is a survivor-centered, jurisprudence-aligned guide designed for students and trainees who will one day stand at the intersection of medicine, law, and human experience. Subjective: what subjective means in forensic contexts. In clinical medicine, S.O.A.P, subjective refers to what the patient reports. In forensic medicine, subjective becomes more complex. It includes the person's narrative, their perception of events, their symptoms, their emotional state, their memory of the timeline, their fears, concerns, and safety issues, their cultural and linguistic context, their trauma-shaped communication patterns. In sexual assault, gunshot wound, burn, and blunt force cases, subjective information is never treated as proof of injury, but as context that guides the examination and medico-legal interpretation. 1.2 Trauma-informed listening trauma affects memory, sequencing, and language. A survivor may recall sensations but not mechanisms. A person exposed to fire may remember heat but not direction. A gunshot victim may recall sound but not distance. The forensic clinician must avoid leading questions, use open-ended prompts, allow silence, validate without confirming details, document verbatim statements, note affect, coherence, and distress without interpretation. 1.3 Subjective descriptions of wounds. Subjective descriptions may include: it felt sharp, I heard a loud bang, I felt burning on my arm, I don't remember how many times I was hit, I woke up with pain in my thighs, I smelled something burning before I felt heat. These statements do not diagnose the wound type. They guide the examiner toward what to look for. 1.4 Subjective data in forensic psychology and criminology. Subjective information also informs risk assessment, behavioral patterns, victim-offender dynamics, memory reliability, psychological state at the time of the event, potential coercion or intimidation. In criminology, subjective accounts help reconstruct motive, opportunity, sequence of events, environmental context. What counts as objective evidence? Objective findings are observable, measurable, and documentable. In forensic medicine, this includes wound characteristics, vital signs, injury patterns, photographs, swabs and samples, clothing condition, biological traces, behavioral observations, environmental evidence on the body. Types of wounds and their objective features. Let's review major wound categories and the objective features examiners document. A. Abrasions, gas. Superficial skin damage may show patterned impressions. B. Contusions, bruises, passa. Blood extravasation. Patterned bruises may indicate objects. C. Lacerations, hiwa, punit. Irregular margins. Tissue bridging. D. Incised wounds, also chop wounds. Clean, sharp edges. E. Stab wounds, sac. Deeper than long, track direction matters. F. Defense wounds, palms, forearms, lateral hands. G. Ligature marks, patterned, horizontal or oblique. H. Bites, patterned injuries, Require photography and swabs. I. Genital and anal findings in sexual assault. Most sexual assaults show no visible injury. Absence of injury does not mean absence of assault. Gunshot wound. GSW. Forensics. Objective findings. Gunshot wounds require precise, neutral documentation. Key objective features include entry wound characteristics, size, shape, margins, exit wound characteristics, if present, presence or absence of soot, stippling, or residue, non-graphic, clothing correlation and bullet holes, number of wounds documented separately. Directionality indicators, without speculation, retrieval of projectiles or fragments, if medically indicated. Burn forensics, objective findings. Burns provide important forensic information about heat, flame, chemicals, or electricity. Document burn depth, superficial, partial thickness, full thickness, burn pattern and distribution. Sparing patterns, for example, clothing, jewellery. Line of demarcation. Associated inhalation signs. Clothing condition, melted, intact, chemical odour. Objective findings in forensic pathology. Pathologists document wound depth, direction, vital reactions, organ damage, hemorrhage patterns, post-mortem changes, evidence of restraint, evidence of neglect. 2.6 Objective findings in nursing and psychology. Nurses document behaviour, pain responses, mobility, hygiene, clothing condition, emotional state. Psychologists document affect, orientation, speech patterns, trauma responses, dissociation, memory fragmentation. Section 3. Assessment. When assessment is done in an emergency setting, medical and surgical procedures takes precedence over forensic documentation, except for extreme situations where you have to do a documented dying declaration, possibly with a witness or second person. 3.1. What assessment means in forensic work. Assessment is the examiner's professional interpretation of the subjective and objective data. It is not a legal conclusion, it is a clinical and forensic analysis. 3.2 Assessing wound type and mechanism. Assessment includes consistency with reported mechanism, possible weapons, accidental versus inflicted injuries, injury severity, alternative explanations. 3.3 Assessment in sexual assault cases. Assessment focuses on injury consistency, biological evidence relevance, psychological impact, safety risks, need for prophylaxis, need for mental health referral. The clinician assesses consistency, not credibility. 3.4 Assessment of gunshot wounds. Assessment considers whether wound features align with reported distance clothing findings versus wound characteristics. Possible projectile path without asserting intent or shooter position. Number and distribution of wounds. 3.5 Assessment of burns. Assessment considers whether burn depth matches reported exposure, pattern consistency, splash versus immersion, sparing patterns suggesting barriers, need for airway monitoring in suspected inhalation injury. 3.6 Assessment in forensic psychology includes trauma symptoms, risk of self-harm, risk of re-victimization, cognitive distortions, memory reliability, behavioral patterns. 3.7 Assessment in criminology includes offender modus operandi, victimology, environmental factors, sequence reconstruction, injury weapon correlation. Section 4. Plan 4.1. The forensic plan. The plan outlines next steps for medical care, forensic processing, safety, and legal procedures. 4.2 Medical plan pain management, wound care, ST, eye prophylaxis, emergency contraception, mental health support, follow-up appointments. 4.3 Medical plan for gunshot wounds, stabilization and hemorrhage control, imaging for projectile localization, tetanus prophylaxis, pain management, 4.4 medical plan for burns, fluid resuscitation as clinically indicated, pain control, wound care and infection prevention, airway monitoring for inhalation injury, 4.5 forensic plan, evidence collection, documentation, photographic, digital, video, blockchain, chain of custody, laboratory submission, clothing preservation, safety planning, mandatory reporting. 4.6 forensic plan for SWS photograph wounds before cleaning, preserve clothing in paper bags, document projectile retrieval, maintain chain of custody, 4.7 forensic plan for burns, photograph burn patterns, document clothing condition, note chemical odors or residues. 4.8 interdisciplinary plan. Forensic work involves police, social workers, psychologists, pathologists, nurses, crisis centres, legal advocates. 4.9 documentation plan. Accurate documentation protects the patient, the examiner, the investigation, the integrity of evidence. Documentation must be clear, neutral, detailed, chronological, free of assumptions. The conclusion. The S.O.A.P framework transforms forensic medical documentation into a structured, trauma-informed, and legally robust process. By integrating subjective narratives, objective findings, including gunshot wounds and burns, professional assessment, and a coordinated plan, forensic practitioners uphold both scientific rigor and human dignity. Thank you for joining this session. Continue learning, continue questioning, and continue building a forensic practice grounded in ethics, clarity, and compassion. PDF-ready bilingual module S.O.A.P for physical evidence as medical evidence with gunshot wounds, burns, and surgery plan OSCE checklists Tagalog English integrated version has. Introduction. Welcome to this 30-minute forensic learning session on using the S.O.A.P framework to document physical evidence as medical evidence. Maligayang pagdating sa 30 minutong forensic learning session tungkol sa paggamit ng S.O.A.P framework sa pagdodokumento ng physical evidence bilang medical evidence. This expanded version includes gunshot wound forensics and burn forensics. Kasama sa pinalawak na version na ito ang gunshot wound forensics at burn forensics. Section 1, Subjective 1.1, Meaning of subjective in forensic contexts. Subjective data includes the person's narrative, symptoms, perceptions, and emotional state. Ang subjective data ay kinabibilangan ng kwento ng tao, sintomas, perception, at emotional na kalagayan. It guides the examination but is not proof of injury. Ginagabayan nito ang pagsusuri, ngunit hindi ito ebidensya ng injury. 1.2 Trauma-informed listening trauma affects memory, sequencing, and language. Ang trauma ay nakaaapekto sa memorya, pagkakasunod-sunod, at wika. Use open-ended questions and document verbatim. Gumamit ng open-ended questions at idokumento ng eksakto ang sinabi. 1.3 Subjective descriptions of wound survivors may describe sensations rather than mechanisms. Maaaring ilarawan ng survivor ang pakiramdam kaysa mekanismo. Examples: I heard a loud bang. May malakas akong narinig na putok. I felt burning on my arm. May naramdaman akong init sa braso ko. 1.4 Subjective data in psychology at criminology. Subjective accounts inform risk, behavior, and event reconstruction. Ang subjective accounts ay tumutulong sa risk assessment, kilos, at pagbuo ng pangyayari. Section 2, Objective 2.1 Objective evidence. Objective findings are observable, measurable, and documentable. Ang objective findings ay nakikita, nasusukat, at nado-dokumento. 2.2 Types of wounds, abrasions, superficial skin damage. Mababaw na gasgas. Contusions, bruising, patterned bruises may indicate objects. Pasa, maaring magpakita ng pattern. Lacerations, irregular tears with tissue bridging. Hindi pantay na punit na may tissue bridging. Incised wounds clean, sharp edges. Malinis at matalas ang gilid. Stab wounds deeper than long, track direction matters. Mas malalim kaysa mahaba, mahalaga ang direksyon. Defense wounds, palms, forearms, lateral hands. Palad, bisig, gilid ng kamay. Sexual assault findings. Most cases show no visible injury, kadalasan walang nakikitang injury. 2.3 gunshot wound, GSW. Forensics document entry / exit characteristics, suit/stippling. If present, clothing correlation, and projectile retrieval. Least is use of anatomical body sketches. Idokumento ang entry / exit characteristics, suit/stippling, kung mayroon, for forensic chemistry, pagsusuri ng damit, at pagkuha ng bala. 2.4 Burn forensics document, burn depth, pattern, sparing, demarcation, inhalation signs, and clothing condition. Idokumento ang lalim ng paso, pattern, sparing, demarcation, palatandaan ng inhalation injury, at kalagayan ng damit. 2.5 Pathology, nursing psychology findings. Pathologist document depth, direction, organ involvement. Idinodokumento ng pathologist ang lalim, direksyon, at organ involvement. Nurses document behavior, hygiene, mobility. Idinodokumento ng nurse ang kilos, kalinisan, paggalaw. Psychologist document affect, orientation, trauma responses. Idinodokumento ng psychologist ang affect, orientation, at trauma responses. In fatal unknown victims of violence where issues of identification of bodies may involve a forensic odontologist, forensic dentist. Section 3, Anatmemava, Assessment 3.1, Meaning of assessment. Assessment is professional interpretation, not legal conclusion. Ang assessment ay profesional na interpretasyon, hindi legal na konklusyon. 3.2 Assessing wound mechanisms. Determine consistency with reported mechanism. Tukuyin kung tugma sa iniulat na mekanismo. 3.3 Sexual assault assessment. Focus on consistency, safety, and medical needs. Nakatuon sa consistency, kaligtasan, at medical needs. 3.4 Gunshot wound assessment. Consider distance indicators, clothing correlation, and wound distribution. Isaalang-alang ang distance indicators, pagsusuri ng damit at lokasyon ng mga sugat. 3.5 Burn assessment. Evaluate burn depth, pattern, sparing, and airway risk. Suriin ang lalim, pattern, sparing, at panganib sa airway. 3.6 Psychology and criminology assessment includes trauma symptoms, risk, victimology, and sequence reconstruction. Kasama ang trauma symptoms, risk, victimology, at pagbuo ng pangyayari. Section 4, Plan 4.1 Medical Plan Pain Control, Wound Care, Prophylaxis, Mental Health Support, Pain Control, Wound Care, Prophylaxis, Mental Health Support. 4.2G, SW Medical Plan Stabilization, Hemorrhage Control, Imaging, Tetanus, Prophylaxis. Pagpapatatag, pagkontrol ng pagdurugo, imaging, antibiotics, tetanus, prophylaxis. Do not forget imaging procedures as X-rays, digital body scans, etc. to locate projectiles tracked in the body and bones involved. 4.3 Burn Medical Plan Fluid Resuscitation, Airway Monitoring, Infection Prevention, Fluid Resuscitation, Airway Monitoring, pag-iwas sa impeksyon. 4.4 Forensic Plan Evidence Collection, Chain of Custody, Photography, Clothing Preservation, Evidence Collection, Chain of Custody, Photography, Preservation ng damit. 4.5 Interdisciplinary Plan Collaboration with police, of course, Forensic scientists and criminologists are involved in the background. Social workers, psychologists, pathologists. Pakikipag-ugnayan sa pulisya, social workers, psychologists, pathologists. 4.6 documentation plan clear, neutral, chronological, detailed. Malinaw, neutral, sunod-sunod, detalyado. O.S.C.E. checklist pack. Puisiyahari kafisa. General S.O.A.P. O.S.C.E. checklist. Subjective open-ended questions used. Verbatim statements recorded. Emotional state noted. Safety concerns identified. Objective wound type described. Measurements taken. Photos taken. Clothing documented. Samples collected. Assessment. Consistency evaluated. Alternative explanations considered. Risk factors identified. Plan. Medical interventions. Forensic procedures. Safety planning. Follow-up. 2. Gunshot wound. OSC checklist objective. Entry wound documented. Exit wound documented, if present. Soot/stippling presence/absence. Noted. Clothing holes documented. Projectile retrieval. Documented. Photos before cleaning. Assessment. Distance indicators considered. Clothing correlation assessed. Wound distribution analyzed. Plan. Stabilization. Imaging. Tetanus. Prophylaxis. Chain of custody. Clothing preservation. 3. Burn forensics OSC checklist objective. Burn depth assessed. Pattern documented. Sparing patterns noted. Demarcation line documented. Inhalation signs checked. Clothing condition recorded. Assessment. Mechanism consistency. Airway risk. Pattern analysis. Plan. Fluid resuscitation. Pain control. Airway monitoring. Photography. Chemical odor documentation. 4. Sexual assault. OSCE checklist objective. Genital/anal findings. Non-graphic. Clothing condition. Biological samples. Behavioral observations. Assessment. Consistency. Safety risks. Mental health needs plan. Prophylaxis. Emergency contraception. Crisis referral. Follow-up. 5. Surgery plan OSCE checklist for forensic injuries. PRE operative. ABC stabilization. Imaging reviewed. Consent obtained. Chain of custody maintained. Photography completed. Intraoperative. Neutral documentation of findings. Retrieval of foreign bodies. Preservation of evidence. Communication with forensic team post-operative. Wound care plan. Pain management. Follow-up schedule. Documentation completed. Evidence sealed and logged. In dealing with children and minors, the procedures are the same and may involve a child psychologist or pediatrician and pediatric psychologist, pediatric sociologist or psychiatrist.